Chapter 29 is the care of patients with non-infectious respiratory problems, upper respiratory problems. The upper airway is the nose, sinuses, oropharynx, larynx, trachea, which you can see here in this picture. They all help with gas exchange by acting as the gateway for the air to get into the body. If you have any problems with any of these parts, what's going to happen with the airflow? It is impaired. And what does impaired airflow do? It interferes with gas exchange. So this is the highest on our ABCs. When we're prioritizing, we have to maintain an open, patent airway. Epistaxis is just a nosebleed. It can happen for a lot of different reasons. It's pretty common though. We have a lot of capillaries in our nose, and that includes the risk of bleeding. So again, lots of causes: trauma, hypertension, blood dyscrasia, which is like leukemia, anytime we have inflammation, tumors, decreased humidity or dryness, leads to more fragile mucous membrane. Patients that are picking or blowing at their nose, a lot of times is how nosebleeds start. Also chronic cocaine use, NG suctioning, all those things. So they can happen anteriorly, which is just in the front of the nose, or posteriorly, which is further in the back. Anteriorly is a lot easier to treat, right? It used to be that you would tell people to tip their head back and pinch their nose, and that is not correct. Then all of the blood is just draining back down the throat into the stomach. Too much blood in the stomach can lead to vomiting, and that puts more pressure on the nose. The nosebleed isn't going to stop. So we want our patients to pinch their nose, lean forward for about 10 minutes is the general rule, because dry tissue membrane, it's kind of like tissue paper actually. It's just kind of dry and brittle, so we want to keep humidity in the nose. So if you're in a dry environment, you can encourage your patient to use a humidifier. And then after the nosebleed, we want to do things like avoid straining or bending over or blowing the nose forcefully. All those things can cause the nosebleeds to just start up again. Obstructive sleep apnea, or OSA. What happens in sleep apnea? So during sleep, muscles relax and the tongue and the neck structures become displaced. So as a result, the upper airway becomes obstructed, but the chest movement is unimpaired. So this apnea creates or decreases gas exchange. It increases the blood level carbon dioxide. It decreases pH, right? So if we have an increase in carbon dioxide, CO2, it's an acid, so the pH goes down. The changes in ABGs stimulate the neural centers of the brain, which kind of wakes the person up. So they wake up after about 10 seconds or more of apnea. They correct the obstruction, and then their breathing continues and resumes back to normal. But after they fall back asleep again, the cycle starts over, and this can happen as often as every 5 minutes. So, that's a lot of hundreds of times a night that the patient can be in this apneic condition. So, risk factors, things like obesity, structural things like having a short neck with a recessed chin, big tonsils, big adenoids, big uvula, which is what? The hanging ball thing in the back of your throat. Cigarette smoking, alcohol, sedative use, all those things can contribute to apnea as well. When people have these apneic periods, then the hypoxia, or the low oxygen level, affects all the cells of their body, especially the cells in the brain. So we see these long-term complications, and they can be severe and life-threatening, especially when the heart along the brain is affected. Hypertension affects up to 50% of people with obstructive sleep apnea. They're at risk for stroke, cognitive deficits due to the lack of sleep, as well as low oxygen, weight gain, diabetes, pulmonary diseases, cardiovascular diseases, and then potentially death if the body is unable to wake the patient up. They can also develop something called cor pulmonale, which we'll talk about later, but that's basically hypertrophy or the failure of the right ventricle resulting from disorders of the lungs, disorders of the pulmonary vessels, or of the chest walls. So lots of potentially serious complications. What's our patient going to look like then? they're going to be tired. They're not getting restful sleep at night when they're waking up all the time. So maybe they feel like they slept all night, but they're real tired in the morning. They might snore really loudly, and this isn't something that they always even are aware of. A lot of times it's co-sleepers that let the person know, like, hey, you snore really loud, and sometimes you stop breathing. They might wake up with headaches, daytime somnolence, which is just tiredness, right? It can cause problems at work. They might be irritable, kind of grouchy. If you're not rested, it can lead to potentially personality changes. So we can do a few different diagnostic tests. One is called the Stop Bang Sleep Apnea Questionnaire. And they basically just ask the patient these yes or no questions to 8 items. The S is for snoring, T is for tiredness, O is for observed as stop breathing during sleep, and P is for treatment for high blood pressure. Remember that I said a lot of patients have hypertension that have sleep apnea. B then is for body mass index, and we're looking at a BMI that's greater than 35. Age greater than 50, a neck circumference greater than 40 centimeters, and then gender, male. So males are more at risk. So we go through this Stop Bang questionnaire. A yes score to fewer than 3 items indicates low risk for obstructive sleep apnea. Yes score to higher than 3 items indicates a high risk. And so this questionnaire, it's super easy to administer and interpret, and it has really pretty high reliability and validity. There it is. Sorry, guys. Validity. So the results correlate pretty well to when they actually go in to do the overnight sleep study. So it's predictive, huh? This is a great segue into sleep studies. So when a patient has a sleep study done, they go to a center and they get hooked up to all these different monitoring equipment and devices to evaluate the depth of sleep, type of sleep, how much respiratory effort they're putting into it, what their O2 stats are, how much their muscles are moving. So they'll use like an EEG, an electrocardiograph, or an ECG, a pulse oximeter, electromyograph, or an EMG. So all these things. You can see the picture here on the slide of the guy with all connected. And anyway, somehow patients are supposed to fall asleep hooked up like that, and then they can be directly observed. The other thing that we can do is grab ABGs, and as you can imagine, we'd expect that there's higher levels of carbon dioxide. So what happens to pH? It will go down, right? And then we can check TSH levels to rule out hypothyroidism, because a lot of the signs and symptoms are similar to hypothyroidism. So different treatment options. If obesity is a contributing factor, we can have our patients lose some weight. We can educate them to refrain from alcohol or sedatives. So just an interesting side note, it only takes 1 drink for your epiglottis to get to become intoxicated and not work as well. So that's why patients after having some drinks might snore or experience sleep apnea more often than not. Additionally, again, I'm off on this side note, but drinking increases your risk of choking as well because of that sloppy epiglottis. So positioning can really help too. So they call it position fixing, and that's just making sure that the patient's not lying flat on their back, where their tongue can obstruct their airway a lot easier. So that's a pretty easy fix. Although you'll find sometimes your patients just keep flipping onto their back, even if their partner is telling them, you're snoring, move over. They still end up finding their way onto their back. A common way that we can help to keep the airway from collapsing is using a non-invasive positive pressure ventilation, or an NPPV, to help to hold open the upper airway. We can also use a nasal mask or a full face mask to allow mechanical delivery of either bi-level positive airway pressure, or BiPAP, you may have heard. We can do auto-titrating positive airway pressure, also called APAP. Or we can do nasal continuous positive airway pressure, or CPAP. So there's some different PAPs out there to help keep that airway open. With BiPAP, the machine delivers a set inspiratory positive airway pressure at the beginning of each breath. So it kind of pushes this air in to open up the airway. And then as the patient begins to exhale or breathe out, the machine delivers this lower end expiratory pressure. So these two pressures help to hold open the upper airway. With our APAP machine, the machine is constantly adjusting. It resets the pressure throughout the breathing cycle to meet the patient's specific needs. CPAP is the delivery of a set positive airway pressure continuously during each cycle of inhalation and exhalation, so each breathing cycle. For any of these positive pressure vents delivered through a face mask, you have to have a little electric compressor. And so you can see that next to the patient in the bed. So it's not, there's equipment that's involved with this. Also, the mask has to fit over the nose and the mouth properly, or just over the nose if it's the nasal CPAP for successful treatment. So the patient has to wear it correctly in order for it to work. That makes sense, right? And these machines can be noisy, but oftentimes patients after this adjustment period really experience positive results from it. They've also come up with a medication to help to manage the daytime sleepiness that can be associated with obstructive sleep apnea, and it's called modafinil, or Attendance, or Provigil are the trade names. And if you can think of it like attention, right? Attendance, at attention, wake up. And it can help patients that have uncontrolled daytime sleep. It helps to promote daytime wakefulness, but it does not treat the cause of obstructive sleep apnea, so we don't do that. Another thing we do not do is sedatives, right? Because we're not trying to put the patient to sleep. The problem isn't that they can't sleep. The problem is that they can't keep their airway open while they're sleeping. There's also a couple surgical options that can be done. The patient can have an adenoidectomy, where they take the excess tissue out of the back of their throat. We've got, this is a fun one to say, uvuloplatopharyngeoplasty, or a UPPP, and that is done for patients that have enlarged tissues as well. They pretty much remodel the entire posterior oral pharynx, or the back of the patient's mouth. And sometimes some patients have to have a trach put in, and that just completely bypasses the obstruction. But that's severe for patients that have really severe sleep apnea, or if they just cannot tolerate a CPAP machine. With which client does the nurse anticipate complications from obstructive sleep apnea following abdominal surgery? A 28-year-old who's 80 pounds, overweight and has a short neck. B, a 48-year-old who has type 1 diabetes and chronic sinusitis. C, a 58-year-old who has gastroesophageal reflux disease for 10 years. Or D, a 78-year-old who wears upper and lower dentures and has asthma. So think about that. And just a tip, when you're looking at questions like this, where you're trying to identify the patient that is at the highest risk, one thing that you can do is to count the number of risk factors. So then the patient that has the most risk factors is the patient that's most at risk, right? So sometimes you'll have multiple choices where, there's a few good options. There's maybe a few of the answers have patients with risk factors, but again, choose the one that the patient that has the most number of risk factors, the highest number of risk factors. So we know that the two biggest risk factors for obstructive sleep apnea are obesity and then having a short neck. So these are anatomical problems. They're not disease-related ones. So the answer here is going to be A, the 28-year-old who's overweight and has a short neck, right? That's two risk factors. Type 1 diabetes, so that's not related to obstructive sleep apnea, especially type 1, which is not usually associated with obesity. Patient C, GERD can damage the larynx over time, but it doesn't cause the tongue to obstruct the airway at all, so that's not an issue. And then dentures alone, in or out, don't contribute to the ongoing problem of sleep apnea either. I just want to speak quickly about upper airway obstructions. And so basically that just happens if the airflow can't get through the nose, mouth, pharynx, or larynx, which we identified as the parts of the upper airway. A lot of different things can cause it, right? Trauma, a patient that has a blockage, a mass, a tumor. Burns can contribute to obstruction. Foreign bodies in there, if the patient's choking, for example. So lots of different reasons. Another thing that puts patients at risk is something called inspissated secretions. And what are those? They're just really, really thick secretions. And so it's up to us as the nurses to take care of them, because these really thick and crusty secretions build up. They can block the airway. So we can prevent it by completing good oral care. Patients that are at the highest risk are those that have unaltered mental status, decreased level of consciousness, if our patients can't communicate, those who can't cough and clear their own secretions effectively, and patients that are at risk for aspiration. Airway obstruction is an emergency, right? So what do we do if a patient has an airway obstruction? We position them differently. We might do suctioning. We might do the abdominal thrust maneuver, which is formerly known as the Heimlich. They can do a cricothyroidotomy. And if you want to see a sort of graphic video of the procedure, you can look at the link below in this slide. They can also do endotracheal intubation and put a tracheotomy in as well. All right, chapter 30 is the care of patients with non-infectious lower respiratory problems. So here now we're talking about the lower respiratory tract. So we need air to be able to flow through the entire respiratory tubular system so that oxygen can reach the alveoli and the ducts for gas exchange. So tiny or any impairment really can lead to problems with the exchange of gas and with tissue perfusion. Lots of these lower airway problems are chronic, meaning that they are not just a temporary situation the patient is dealing with. They're going to be long-term, and they are progressive, meaning that they get worse with time. Asthma can occur at any age. About half of adults with asthma also have the disease, though, in childhood. But this means that half are new cases as adults. It affects 18.5 million people in the United States. It's more common in urban settings than in rural settings, and it can kill, or it has killed, over 3,600 people every year. It is a chronic disorder, meaning it's not curable, where the airways become temporarily blocked or obstructed, so air cannot get through the lumens in or out of the lungs. The blockage can happen a couple of different ways, and it often happens in combination. So one thing that happens is with bronchospasms. So bronchospasms are these sharp contractions of the bronchial smooth muscles. So the muscles are contracting, and as they contract or squeeze, the airways narrow. And this happens as a hyperresponsiveness to stimuli, basically. So they kind of overreact to stimuli. And another way we say stimuli are different triggers. Another thing that happens in asthma is edema. So the microvascular leakages, the airway capillaries, dilate. They get bigger and they leak, increasing the secretions, which cause edema or swelling, and it makes it harder to clear the mucus. And then the third way that the airway is obstructed is with these mucus plugs. So there is an increase in mucus-secreting cells with expansion of mucus-secreting glands, and these can create these mucus plugs that kind of plug up the airway. So this happens in response to different trigger exposures. And inflammation triggers for asthma for some adults When allergens bind to specific antibodies, especially the immunoglobulin E or the IgE, these antibodies are attached to tissue mast cells and the white blood cells called basophils, which are filled with chemicals that can start a local inflammatory response. Some chemicals, like histamine, for example, start this immediate inflammatory response, and that can be blocked by medications like diphenhydramine or Benadryl. Others, such as leukotriene, are slower, and they can cause these later prolonged inflammatory responses. And those are blocked by different drugs like montelukast or Singular. Chemicals also are attracting more white blood cells to the area, which continues this response of blood cell dilation, capillary leaking, causing mucous membrane swelling, increased mucus production, which narrows the lumen even more. So you can see that there's just kind of this trifecta that leads to reduced airflow. There's also different things, different pharmacological responses. So aspirin and other NSAIDs can trigger asthma in some adults, not from an allergy, but from an increased production of the leukotrienes that I was talking about, when aspirin or NSAIDs suppress these other inflammatory pathways. There's environmental factors. Exposure to dry or really cold air can trigger asthma in some patients. Air pollution as well, which is why we see more asthma in urban settings versus rural. And then infections can contribute. Some patients have exercise-induced or related asthma attacks, and GERD. So GERD can trigger asthma in some adults and causes asthma symptoms at night, because the highly acidic stomach contents enter the airway, and so that makes any pre-existing tissue sensitivity even worse. So what you're going to hear when a patient is experiencing airway constriction are wheezing lung sounds, and I'm going to have you listen to what that sounds like. So you can hear how the wheeze is louder on exhalation when the patient is exhaling. The air is trying to get out. We might, it can also be present with a cough, which typically increases when there's inflammation. We might see the patient using accessory muscles, which are what? The muscles in the neck, the muscles in the shoulders, yes. It can lead to shortness of breath, chest tightness, hypoxia or low oxygen. We might see cyanosis or blue around the patient's lips, maybe on their fingers. And symptoms can get worse at night or when their triggers are present. When a patient is having an asthma attack, it's essential that we assess and treat them quickly. We want to look at their vitals. We want to look at any allergies that they might be having, what medications they're on. If a patient is having an asthma attack, how would you expect that their vitals would be affected? Well, they're going to be tachycardic. They're going to have increased respirations. O2 sats are going to be down. Blood pressure might be up immediately, but then might go down as the CO2 levels rise. They're probably going to be pretty anxious, right? So what do? We give a short-acting beta agonist, which helps to relax the constricting muscles to allow air in. We can give IV corticosteroids, depending on how severe the attack is. We want to make sure that they're getting oxygen, right? We said that they're probably going to have low oxygen levels. Positioning, so sitting up in high Fowlers is going to help them to breathe better, and then provide a calm atmosphere. As I mentioned, they're probably going to be pretty anxious, so we don't want to add to their anxiety by running around all out of control ourselves. So try to keep the atmosphere calm as well. There's something called status asthmaticus, which is a severe life-threatening acute episode of airway obstruction. It intensifies once it begins, and it often does not respond to usual therapy, like albuterol, for example. So the patient comes into the ED with extremely labored breathing and wheezing. You're going to see accessory muscles being used, distension of neck veins. If the condition is not reversed, the patient might develop a pneumothorax and possibly arrest. So very important that they get treated. We want to get them IV fluids. We want to do these potent systemic bronchodilators, steroids, epinephrine, oxygen, all these things we give immediately to help to reverse the condition. We can give them magnesium sulfate, which helps with bronchodilating and anti-inflammatory effect. And we want to be prepared for emergency intubation, right? If they're wheezing and all of a sudden you don't hear wheezing anymore, what does that tell you? That sudden absence of wheezing indicates that there is a complete airway obstruction, which would require a trach to be placed, a tracheostomy. Once their breathing improves, then we can just manage it the way that we manage asthma in general. So how do we treat asthma regularly? There is on chart 36, 30-6 on page 568 in your textbook. There's a chart that goes through all of the different meds that can be used for asthma. I'm just going to kind of summarize them here for you. So bronchodilators cause bronchiolar smooth muscle relaxation, but have no effect on inflammation. So they don't reduce inflammation at all. They just open up the airway. So if airflow obstruction is caused by bronchospasm and inflammation, you have to use at least 2 different types of drugs because bronchodilators, again, they do not affect inflammation. So we've got a couple different examples here. One example of a bronchodilator are our beta-2 agonists. They bind to and stimulate the beta-2 adrenergic receptors in the same way that epinephrine and norepinephrine do. So they increase smooth muscle relaxation. They open it up. We also have examples of the short-acting beta agonists are albuterol. So that's a pretty common medication that we see. They provide rapid but short-term relief. They are inhaled, and they're most useful right when the attack is beginning, kind of as relief, or as pre-medication when the patient is going to start an activity that probably is going to induce an attack. So maybe they know that the pollen count is really high outside, and they're gonna go outside, so they might use their inhaler, their albuterol before they go out, or before they exercise, they might take a puff of their albuterol to help to prevent an asthma attack from occurring. We also have long-acting beta-2 agonists, and they're also used by inhaler directly to the site of action, which is down in the bronchioles. If you use long-acting agonists correctly, you're not going to need to use your rescue drugs as often. These take a long time to build up an effect, but the effects are longer lasting, long-acting beta-2 agonists. They're really helpful to prevent an asthma attack, but if the patient's going to have an acute attack, if it's coming on suddenly, these are not the meds to take. So salmeterol or Ceravent is an example of a long-acting beta agonist. You have to be careful though, because they can be associated with deaths, especially when they're used as an only therapy for asthma. So we want to make sure that we're telling our patients to use both types of inhalers, the short-acting and the long-acting. Okay, so the second class then are cholinergic antagonists. And so these are anticholinergic drugs or long-acting antagonists. Similar to atropine, they block the parasympathetic nervous system, which increases bronchodilation and helps to decrease secretions as well. So the main drug in this class is Atrovent, right, which is used as an inhalant. Most cholinergic antagonists are short-acting, and they have to be used several times a day. There are long-acting agents, though, like tiotropium or Spiriva, which you can use once a day. We also have some different anti-inflammatory agents that help with inflammation. So they're inhaled. When they are inhaled, they have fewer systemic side effects than if they're taken systemically. And all of the anti-inflammatory drugs, whether they're inhaled or taken orally, are controller and prevention drugs only. They're not for an acute attack. And so this is things like fluticasone or Flovent, prednisone, those types of things. Then lastly, we have the leukotriene modifiers, which are oral meds. They work a couple different ways to help control asthma, but they have to be taken on a scheduled basis. So montelukast or Singulair block the leukotriene receptor. There's also Xylutin or Zyflo, which prevents the leukotriene synthesis. So know which meds are rescue meds, and know if you're going to be giving your patient albuterol, what some of the common side effects are. So then what do we tell our patients? Well, the best way to avoid an asthma attack is to avoid triggers, right? If the patient smokes, we want to tell them to stop or avoid smoking. We want to, again, teach which inhalers are rescue, which are not. Using the rescue inhaler 30 minutes before exercise. And then know how to use inhalers. So chart 37 in your book talks about how to use an inhaler. If you don't know how to instruct your patients to properly use an inhaler, please make sure that you're checking that out. And then the last bit of information is to always carry a rescue inhaler so that if an attack happens, the patient's able to relieve the symptoms. A client newly diagnosed with moderate asthma asks whether he can just take salmeterol instead of salmeterol and albuterol because he read that they're both beta agonists. What is the nurse's best advice? Please read through the answers, select your choice, put me on pause, and when you're ready to move forward, you can hit play. All right, so the answer here is C. The nurse's best advice is no. Albuterol is used to relieve the symptoms during an actual asthma attack, and salmeterol is used to prevent an attack. You need to take both. So albuterol is a short-acting beta agonist that has an immediate onset of action with a short duration. It's used as needed to relieve or rescue and to stop an actual asthma attack. Salmeterol is an inhaled-only, long-acting beta agonist that has a slower onset of action, but a longer duration. So that one you take every day, whether you have symptoms or not, to prevent or control asthma, not to stop an attack that has already started. It has no real benefit as a rescue inhaler. So both forms of the beta adrenergic agonist are needed in the management of moderate asthma. Chronic obstructive pulmonary disease, or COPD, is the most common chronic lung disease that affects 15.8 million Americans. More than 10% of nursing home residents have it, and it's the fourth leading cause of death in the United States. So what is it? COPD is actually an umbrella term that could refer to emphysema and chronic bronchitis, and more commonly a combination of the two. It can result from exposure to cigarette smoking or secondhand smoke, recurrent or chronic respiratory tract infections, environmental fumes or pollution. There's also familial or hereditary factors, such as alpha-1 antitrypsin deficiency. So AAT is an enzyme that we normally find in the lungs that helps to keep excessive protease activity down, so that only inhaled pollutants are broken down and not the lung itself. This is a deficiency that is passed down from both parents, and it results in the development of COPD at a young age, even without that exposure to irritants. There are some differences between emphysema and between chronic bronchitis. The pathophysiology is different, but remember, a lot of patients that have emphysema also have chronic bronchitis. So emphysema is the loss of lung elasticity. The alveoli are damaged by chronic inflammation, and small airways start to lose their elasticity and have fewer large sacs or areas for air exchange to take place. This hyperinflation of the lungs increases the amount of air that gets trapped in the lungs, which in time flattens out the diaphragm, making it really not very effective and requiring them the use of accessory muscles to get rid of air. Remember we did the experiment earlier in class where you took a deep breath in, blow it halfway out, take another deep breath in, blow it halfway out, another deep breath in, blow it halfway out. Right, it starts to get really difficult because we're trapping a whole bunch of air in the lungs and the patient's never able to fully exhale, so then they can't get a good breath in. Chronic bronchitis, on the other hand, is an inflammation of the bronchi and bronchioles that's caused by exposure to irritants like cigarettes. It causes inflammation, vasodilation, mucosal edema, congestion, bronchospasms. Chronic bronchitis only affects the airways, not the little alveoli. It increases the mucus secreting glands that can block smaller airways and definitely narrows the bigger ones. Also, having all that excess mucus around is a great breeding ground for bacteria, so these patients are at a much, much higher risk for developing an infection. What are we going to see in our patient with COPD? When they're in the hospital, we want to make sure that we're assessing them frequently, at least every 2 hours, with airway maintenance being our most important function, right? On our priorities, we've got our ABCs, airways up at the top. So we want to be assessing them frequently. And there's 3 primary symptoms that we see: cough, sputum production, and we see lots of this thick yellow sputum, and then dyspnea on exertion. And dyspnea on exertion sounds, like somebody is maybe getting breathless when they climb the stairs. But as COPD progresses, exertion means things like getting dressed, eating, drinking, completing other personal cares, even sleeping. So all these things, the patient is exerting energy when they do them, and with their COPD, they're not able to. So, this really does affect every aspect of their lives. We're going to see rapid, shallow respirations, and they have a longer expiratory phase, so they're trapping a bunch of air, remember? So their breathing out is longer than breathing in. Sometimes the respiratory rates, so they're usually increased, but it can climb as high as 40 to 50 breaths a minute, which definitely needs medical attention, right? That level of hyperventilation can lead to some pretty big acid-base imbalances, as well as just the muscles wearing out, right? If you use any muscle too much, it can fatigue, and so the lungs are the same; they're a muscle. But if they get overworked, they can fatigue and burn out. We're going to probably hear reduced breath sounds, wheezes, or other abnormal sounds because the lungs are really tight and inflamed. Sometimes there's crackles as well because of the fluid. And then the client too, in time, their chest becomes barrel-shaped. So because their breathing pattern changes, so does their physical appearance as well. You'll see them sitting often in this orthoptic position. So if you look at the top right picture, you can see a gentleman. It's also called a tripod position. And sitting this way, it facilitates breathing. It's hard for COPD patients to breathe well when they're lying flat, so they often find themselves in this position. It also helps them to be able to use their chest and abdominal muscles to assist in their breathing. We're going to see most likely weight loss because if they have shortness of breath when they're eating, they're not going to be taking in as many calories. Progressive airflow obstruction leads to hypoxia, or low oxygen levels. And low oxygen levels, what we can see is like thin, dry skin. We might see cyanosis, especially in patients with bronchitis. We can see clubbing of the fingers, as you see in the bottom right-hand picture, where there's almost these little bulbs at the end of the fingers. That's the result of chronic hypoxia. Delayed cap refill, The patient is going to have chronic low oxygen, so COPDers often have O2 sats that are less than 90%. Usually, though, they'll know their range, and it's typically what we want to try for is between 88 and 92%. So the thought used to be that you did not want to treat your COPD patient with oxygen therapy, but that has not been proven to be best practice. So make sure that you get your patient on oxygen, and we'll talk about that in a couple slides. Other things you're going to see, maybe swelling in the ankles and feet from dependent edema, possible right-sided heart failure, and then psychosocially they're affected. They might be feeling things like anxiety, isolation, changes in their sexual roles, in their relationships, financial concerns, maybe they can't work anymore, they're on disability. Medications are expensive. It's a progressive chronic disorder, so they're going to need meds for indefinitely. They're expensive. Does the patient have access to support groups? Are they able to do they have the energy and the ability to get out of the house to go to them? If not, there's lots of online support groups available to patients too that they can attend. There are some different lab assessments and diagnostic tests that we can use. Pulmonary function tests just help us to determine lung volume, flow volume curves, and diffusion capacity. And they'll test the patient before and after they take a bronchodilator. Tests that, so they can test vital capacity, residual volume, forced expiratory volume, and total lung capacity. All of these are affected by COPD, but residual volume really is the most affected. So they make the diagnosis mostly made on the FEV1, or the forced expiratory volume, in 1 second test. It can also be expressed as a percentage of forced vital capacity, or FVC that you might see. As the disease progresses, the ratio becomes smaller. Another lab or diagnostic test they can do is a chest x-ray. That shows more of the structure, so we can see changes in heart and lung size. It can rule out other diseases, and then just kind of monitor the progress. It can show the hyperinflation of the lungs. It can show a flat diaphragm that happens with advanced emphysema. The CT scan of the chest shows more tissue than the x-ray. Bulli are these enlarged air spaces that do not contribute to ventilation, but they occupy space in the chest. They can rupture, which is a problem, and they can lead to a pneumothorax, and they may need to be surgically removed. We can do ECG to detect changes in heart rhythm, look for dysrhythmias. ABGs, so we always want to get a baseline ABGs and then recheck to see how the patient's responding to treatment. Oxygen in blood decreases, so we know the PaO2 and the PaCO2 increases. So the result is this chronic respiratory acidosis, followed by metabolic alkalosis when the kidneys start to hang on to bicarb to compensate. So you can see an elevation in bicarb on ABGs, but pH usually stays low and acidic, and some patients have hypercarbia. So education, really, it's very, very important to get the patient on board as a partner in their care. Energy conservation is something as nurses that we're going to really want to stress the importance of to our patients. And so what is energy conservation? It's spacing out activities throughout the day and then prioritizing activities like eating, for example. So we wouldn't want to have them get dressed and then eat breakfast because that might be too much. Better to eat breakfast and then get dressed if they still have the energy. We want to encourage small, frequent meals that are really high in calories and in protein. So it takes a lot of energy to eat. Would we want our patient to eat raw carrots, or would it be better for them to have maybe softer steamed carrots? So we would ideally want the softer foods because it takes less effort to chew. We don't want to encourage like drinking fluids with meals because it might limit the amount of food that they're going to eat. But totally we would want to supplement with like Ensure, for example, throughout the day. Coughing. So why do we want to talk to our patients and encourage coughing? Because coughing helps to clear secretions. So we do want to encourage our patients to cough. It's the best way to clear secretions. And then also there's some other breathing techniques. So if you look at chart 3010 in your book, it'll talk to you about pursed lip, diaphragmatic breathing. And in this technique, the patient lays on their back and they focus on breathing from their abdomen with a book or a stomach on their abdomen to help to create resistance. So you can check that out in your book to learn a little bit more. Medications for people with COPD are very, very similar as for meds for people with asthma. So we use our beta-adrenergic agonists, cholinergic antagonists, xanthines, corticosteroids, and hormones, which are all in chart 36 in your book. Mucolytics we can use as well to help to thin secretions, and we can use nebs with Mucomist. So what are some dangerous medications? What meds would it be potentially dangerous for a patient with COPD to take? Think about sedatives, opiates, narcotics, anything that suppresses the respiratory drive. We want to be really, really mindful of and wary of giving to our COPDers. So if a patient's having an exacerbation, let's talk about treatment. So what I was saying earlier is that as far as oxygen therapy goes, the thought used to be that patients with COPD were at a really high risk for extreme hypoventilation with oxygen therapy because we thought that they would have a decreased drive to breathe as the blood oxygen levels rose higher. This concern, though, has not been shown to be evidence-based and actually has been responsible for ineffective management of hypoxia in patients with COPD. So I want you to remember this. This is very important. All hypoxic patients, even those with COPD and hypercarbia, should receive oxygen therapy at rates that are appropriate to reduce hypoxia and bring SpO2 levels back up between 88 and 92%. Okay? Know, too, so one way to recognize if the patient is hypercarbic, or they have too much CO2, too much can make you delusional, and then tired. So be kind of on the lookout for that. One way that we can monitor this is to do our continuous pulse ox, right? Again, rest, limit activities, focus on breathing, oxygenation. Remember, too, that fluids help to thin secretions, and so we don't want to limit fluids in COPD patients because we want their secretions thin so that they can cough them up and get them out of their body easier. Which interventions are important for the nurse to teach a client with severe chronic obstructive pulmonary disease in order to help ensure adequate nutrition? Select all that apply. So go ahead and take a moment, put me on pause, and make your choices. Okay, so if you're listening again, I hope you've already chose your answers. Let's go through and see. So A, avoid, and remember the best way to approach these select all that apply questions is to go through each one as if it were a true or false question. So A, avoid eating gas-producing foods. What do you think? Yes, so gas-producing foods contribute to a feeling of fullness early satiety, and interfere with adequate food intake. So we do want to talk to them about avoiding gas-producing foods. How about B, coughing and clearing mucus right before eating? Yes, this is true as well. It makes the client more comfortable, not to mention those that are eating with him or her, and it also helps to prevent the need to cough during a meal, which would interrupt the process. It's not just like a quick, it's a long, hacky cough. How about C, drink plenty of fluid with every meal? No, we want to discourage drinking liquids during the meal because it contributes to feeling full faster and reduces the amount of foods they eat. How about D, eat smaller meals more frequently? Yes, so we do want to encourage that. 4 to 6 small meals daily instead of the 3 big ones helps to improve nutrition by not tiring the client out as much. Physiologically, a smaller appearing meal looks less daunting to somebody who might not be feeling very hungry. So it kind of tricks them into eating more. All right, how about E, rest immediately following a meal? No, we want them to rest before they eat, right? F, eat more raw fruits and vegetables? No, eating raw fruits and veggies requires considerable chewing and is likely to tire the client out without actually increasing the amount of calories that they take in. Okay, and then the last one is G. Use your bronchodilator about 30 minutes before each meal. And yes, we do want to do that. It makes it easier for the patient to breathe by reducing shortness of breath so that they're able to concentrate on eating instead of concentrating on breathing. So A, B, D, and G. Cystic fibrosis is an inherited recessive, meaning that it needs to come from both parents, chronic progressive disease, often fatal, that affects the body's exocrine mucus-producing glands. It affects a lot of organs. It can lethally impair the lungs. And it comes from blocked chloride transport in the cell membrane that causes this formation of thick mucus that ends up leading to issues in all of these organs that I'm going to talk to you about. So lungs, it narrows the airways related to the mucus that's present, as well as infection. The patient's more at risk for developing infection. They have chronic bronchitis. They can have a dilation of the bronchioles. Lung abscesses can form, pneumothorax, arterial erosion, hemorrhage, respiratory failure, and they may end up needing to get a lung transplant. The pancreas is affected as well. They can have pancreatic insufficiency. It leads to malnutrition, intestinal obstructions. They can have diabetes related to the loss of insulin production. Remember, insulin production happens in the pancreas. They can develop cirrhosis of the liver. Salivary glands are affected. The testes are affected, so males that have cystic fibrosis can be sterile or are often sterile. And then patients develop this abdominal distension, vitamin deficiencies, especially the fat-soluble vitamins, which is what, A, D, E, and K. So this, what we see with the poor food absorption are these bulky, black, foul-smelling stools. So nutrition education is super important. We want to teach the importance of pancreatic enzyme replacement, which helps to digest food so that intestines can absorb, give supplemental iron, do daily weights to make sure that the patient is getting enough calories, that they're not losing weight, and then daily chest physiotherapy. So if you haven't checked out the video in the lab link yet, please make sure that you do that. A client with cystic fibrosis who is 2 months post-operative from a bilateral lung transplant wants to begin riding his bicycle again, as his pulmonary specialist says he can do, but his wife is concerned that this will wear out his new lungs faster. How will the nurse advise this couple? So read through the answers, put me on pause, and then hit play when you're ready to hear. So this answer is A. Remind the wife that activity does not damage or wear out the lungs, and that exercise will reduce the risk for other health complications. Although the disease process can cause problems eventually in the new lungs, activity does not damage the lungs. All exercise in a client who has undergone a lung transplant for cystic fibrosis must begin slowly and progress at an appropriate rate for each of the client. There's not a restriction on the type and an intensity of the exercise unless they have some other health problem. Before we talk about what chest tubes are, I just want to quickly review what happens when we breathe, just the respiratory process. So when we breathe, the diaphragm descends into the abdominal cavity during inspiration, which causes this negative pressure in the lungs. The negative pressure in the lungs draws air from the area of greater pressure, or the atmosphere, into the lesser area of pressure, or the lungs. Inside the lungs, the air passes through the terminal bronchioles into the alveoli to oxygenate the body tissues. And then at the end of inspiration, the diaphragm and intercostal muscles relax and the lungs recoil. As the lungs are recoiling, the pressure in the lungs becomes higher than the atmospheric pressure, causing that air, which contains carbon dioxide, water, to move from the alveoli into the lungs, into the atmosphere. So we want to maintain that negative pressure so that we can take a good breath. When we have a compromised pleural space, so chest tubes don't go into the lungs, they go into the pleural space, or the area that's kind of surrounding the lungs, and they go in to let the lungs reinflate, and to drain blood, fluid, pus, or air to prevent them from returning to the chest. It can be used to help treat pneumothorax, which is air in the pleural space, hemothorax, which is blood in the pleural space, empyema, which is infected fluid in the pleural space, pleural effusion, which is where the cavity around the lungs starts to fill with fluid, and also the cryothorax, which is lymph from the digestive system that starts to accumulate in the pleural cavity. The tubes, usually the patients have more than one tube. They usually have a tube up top, which is for draining air, and then a blood drainage tube a little bit lower down. A lot of times too, then there'll be a collection chamber, and that's what you can see in the picture here on the slide in the upper right hand corner. So the two tubes are placed. We cover the wounds with an airtight dressing. Then there is about 6 feet of tubing that comes out of that and is connected then to this collection chamber. Now the tubing, it's important that there's not dependent loops. You can coil it up on the bed, but we want the chamber itself to be below the level of the chest. The canister drainage system can be a little different depending on what type you have. But so there's a stationary chest tube drainage system that uses a water seal mechanism, and that water seal acts as a one-way valve, and that keeps the air or the liquid from going back into the chest cavity. So we want it to come out. We don't want it to go back in. You'll see sometimes these three-chamber systems. And so the tube from the patient is connected to the first chamber, and that's the drainage collection container. The second one is the water seal, and that's, again, to prevent air or whatever from moving back up into the tubes and back into the pleural space. And then the third chamber, if you're hooking them up to suctioning, is the suction regulator. So when you set up the system, chamber 1, which is the one closest to the patient, doesn't have fluid in it at first. The tubing from the patient goes into that chamber, and then as it does, the tube connects chamber 1 with chamber 2. So chamber 1 collects fluid draining from the patient. We usually measure it every hour during the first 24 hours, and we never, ever, ever want the fluid in chamber 1 to fill up to the point where it comes into contact with any tubes. If the tube from the patient enters the fluid, the drainage can stop, and then that can lead to a tension pneumothorax. So we want to make sure that we're monitoring it, that we're draining it appropriately. Chamber 2 then is the water seal, and again, it keeps the air from going back up into the client's pleural space. And so as that trapped air leaves the pleural space, it goes through chamber 1 and then goes into chamber 2. Which should always contain at least 2 centimeters of water as that water seal. When the air is passing through that, we see the water bubble. So once all of the air has been evacuated and taken out of the pleural space, the bubbling will stop. So we also want to be checking that water level every shift and make sure that we're adding sterile water to that chamber to the level it's marked. It's kind of hard to see in this picture, but it's marked so that you know how much sterile water needs to be in there. So bubbling happens, but it's normal. and it's expected, especially or when the patient is exhaling. And then we can also see something called titling. So it rises and falls, rises during inhalation, falls during exhalation, and that's titling. If we don't see that happening, then that means that either the lung is fully re-expanded, and that's great, or that there's an obstruction in the chest tube. The third chamber then is the suction control of the system, and there's different types of suction. You can do wet or dry. You're doing wet, it's ordered by the provider to what level you're going to use. Usually it's about 20 centimeters. And then it's turned up until there's gentle bubbling. If there's dry suctioning, then you do the suctioning on the device itself. So what do you do if the canister becomes detached? I want you to look up in your book on page 591 what you should do. If the chest tube becomes dislodged from the patient, we want to make sure that you cover the opening immediately with petroleum gauze and apply pressure to prevent negative inspiratory pressure from sucking air into the chest. You want to make sure to call the provider and have an assistant collect equipment for tube reinsertion while you're keeping the opening closed. You want to reassure the patient, monitor him or her really closely for signs of a tension pneumothorax, and then tape on 3 sides only. So you can see in the photo here, the gauze is only taped on using 3 sides, and that just allows the air to escape. If the tube disconnects from the collection canister, you can put the end of the tube in water and clamp closest to the patient. The chest tube of a client who's 12 hours post-op from a lobectomy separates from the drainage system. What is the nurse's best first action? Pause me. Okay, well, I hope you said D. Place the end of the disconnected tube into a container of sterile water that's positioned below the chest. So this soon after surgery, an open chest drainage tube can have air suck through it back into the client's chest and collapse the lungs, which is an emergency. So you do want to call the surgeon or the rapid response team. The first thing that you want to do, so in the question it says the first action, or maybe you'll see it on other questions as your initial action. So that's what you want to do first is the first thing that you want to do is put that end into sterile water, and then you can make those phone calls. Because the chest tube is still in the client, the occlusive dressings is not going to help to prevent the lung collapse. And then setting up a new drainage system, that can wait until after the tube is secured. Chapter 31, Care of Patients with Infectious Respiratory Problems. In pneumonia, we have 2 to 5 million cases every year, with over 1 million adults hospitalized in the United States. And more than 50,000 of these people die. The rates are higher among older adults, patients that are in nursing homes, people in the hospital, people that have swallowing difficulties, neurological problems, and those on beds. So think about this. Who's at high risk for aspiration? Enteral feeding, right? People that have decreased level of consciousness, vented patients, chronic lung disease, hello, cystic fibrosis, history of antibiotic usage, endotracheal intubation, those that are undergoing invasive procedures. So there's lots and lots of risks. The immunocompromised patient as well is at a big risk. The really young, so those under 2, and then the really old. So pneumonia can be an acute or a chronic infection. It can affect one lung, it can affect both lungs, and it's got a whole bunch of different causes. So bacteria, virus, chemical irritants, fungus, mycoplasms, toxic gases, aspiration of food, water, fluid, like saliva, vomit. So many different things can cause pneumonia. When we classify pneumonia, we go based on the type of the organism involved, so whether it's bacterial, viral, aspiration. There's also different types of pneumonia that you need to know for reimbursement purposes. So these are a few different types of pneumonia. We have community-acquired pneumonia, which happens when clients develop it out in the community. They can't be a resident of long-term care. There's hospital-acquired pneumonia, which is pneumonia that happens more than 48 hours after admission. So here it's really important that we're doing when we're doing our admissions, that we're asking all the questions, signs and symptoms to rule out community-acquired pneumonia. There's also something called ventilator-associated pneumonia, and that happens when a patient develops pneumonia after being on a vent for 48 to 72 hours. And then there's healthcare-associated pneumonia, and that is for patients that live in nursing homes or assisted living homes. They get IV therapy, wound care, antibiotics, that have had chemo in the last 30 days, or have been seen in a hospital or dialysis clinic in the last 30 days. So what do our patients with pneumonia look like? Well, we are going to see fever. They might have chills, flushed cheeks. They might be sweaty. They can have a cough with or without sputum from fluid accumulation. This pleuritic chest pain or inflammation or pain when they inhale. They can be short of breath. They might have malaise or just a serious lack of energy, headaches, anorexia, so the body's focused more on breathing. It's really hard to eat. We might hear in our lung sounds crackles, wheezing maybe if there's inflammation present, and these are all over the areas that have pneumonia. They might be hypotensive, especially our older adults. They can have a high respiratory rate due to anxiety or pain from an increased work of breathing, related to decreased lung compliance, or just the lungs aren't able to expand. They might have hypoxemia, dehydration, sepsis, dysrhythmias. When cardiac tissue is hypoxic, you can develop dysrhythmias. Sometimes the sputum that they produce might be blood tinged, and that is just from inflammation as fluid from capillaries kind of move into the alveoli. The most common symptom in older adults is a change in cognition with acute confusion, and that is directly related to hypoxemia. There's lots of different diagnostic tests we can do, but a lot of times the chest x-ray can kind of show us what we need. It can take a couple of days, though, after the symptoms start to get a clear picture of what's going on. We can get a CBC to assess white blood cell count, except in older adults. We want to get ABGs to establish baseline. We want to look at serum electrolytes, BUN and creatinine levels, because the patients could be dehydrated. With dehydration, we might see hypernatremia, and so we see an elevated BUN then, right, if the patient's dehydrated. Interventions, we want to make sure that our patients are on oxygen, that we're giving them fluids, that they're practicing incentive spirometry. And then for meds, there is antibiotic therapy, and then there is also the pneumovac vaccine. So we have the opportunity for some good patient education here. We want to tell them about frequent oral hygiene, good hand washing, obviously. It reduces the spread of infection. If the patient's on a vent, we need to make sure that we're doing oral hygiene every 1 to 2 hours with chlorhexidine, because dental plaques and bacteria can make their way down the vent tube and lead to pneumonia. We want to make sure that we're changing oxygen tubing when it's contaminated. There's different hospital policies for how often you should be changing tubing, but it's something that gets overlooked a lot. We want to talk to patients about the importance of vaccination, the pneumovac, especially patients that have risk factors for developing pneumonia. If you can't remember what those are, go back a couple slides and review. Patients that are receiving antibiotics that are having rigors, and that's just like really extreme shaking. If they have an increase in a fever, or if all of a sudden they have a cough that's producing sputum, that might tell us that the med is ineffective after the first 24 hours, right? We expect that after they've been taking their antibiotic that these symptoms are going to start going away. So if they're not, then maybe we got the wrong antibiotic. We want to make sure that we're increasing oral fluids to 2 liters a day. Remember that fluids are the best and most effective way to thin secretions, even more effective than coughing. And then incentive spirometer every 1 hour WA. What is WA? When awake, or TCDB, which is turn, cough, and deep breathe. When reviewing lab values for a client admitted with pneumonia, which result would cause the nurse to collaborate quickly with the healthcare provider? All right, the answer here is B. PaO2 is 68. Remember that, even though all these other values are abnormal, PaCO2 is just a little elevated. They're expected findings in clients with pneumonia or that have any other severe infection, right? We expect a higher white blood cell count. Blood sugar might be a little higher too. But the very, very low PaO2 indicates severe hypoxemia, and there's a great risk for death without immediate intervention. So remember, PaO2, the normal range is between 80 and 100, so this is significantly low. Tuberculosis might be one of the oldest diseases in the world. It's very highly infectious, and it's caused by Mycobacterium tuberculosis. It's transmitted by aerosolization. It's airborne. So when a person that has tuberculosis laughs or sneezes, whistles, sighs, the droplets come out, and then they can be inhaled by other people. What happens then is that patients form these tubercles, which are nodules or swollen lymphocytes and epithelioid cells that end up forming these lesions in the lungs. So right away, we may not always see symptoms that say, oh my gosh, I have tuberculosis. A lot of times they're vague, a little more general. So having a cough that lasts for more than 2 weeks, a fever, weight loss. And weight loss that's significant is anything more than 3 pounds a week. Some other really common side effects are night sweats, feeling really weak, maybe chills are present, with hemoptysis. And this is usually kind of the sign that brings people in. Hemoptysis is bloody sputum. So people see that, and then they come to the ED or to the doctor. And so there are a few different diagnostic tests available. One is the MANTO, or the PPD, Purified Protein Derivative. And this is the most common test. It's relatively inexpensive. They just take a small amount of purified protein derivative, and you should know it by both names. And they place it intradermally under the forearm, and then it's read again in 48 to 72 hours. If there's an induration or a swelling of greater than 10 millimeters, then that indicates that the patient's been exposed to TB and possibly has the infection. Note, though, that there's a few different reasons why you might see a positive PPD. So, as I mentioned, exposure to the bacteria is one, but maybe the patient has had TB in the past and they've been treated for it. Also, patients that have had the immunization, Bacillus calmette-guerin, or the BCG, that would also indicate that they have, or that they would have a positive PPD. The BCG is not common in the U.S. It's more often in countries where tuberculosis is common. And then, of course, the last reason you'd have a positive PPD is if you actually had tuberculosis. Once the skin test is positive, then we always go back, because there's so many different reasons why PPD might be positive. Then we go on to a chest x-ray. And so chest x-ray can tell us if the TB is active or if we're just looking at old healed lesions. But it can take about 6 to 8 weeks from the time of exposure, from the time a person has been exposed to TB, to actually have a chest x-ray that's showing these lesions. There's also sputum cultures that are used to confirm diagnosis, where they take samples at different times throughout treatment. A lot of times this is after meds are started, and it just helps us to gauge how treatment is going. We would expect that they're negative after 3 months of effective treatment. There's nucleic acid amplification tests, or the NAAT, where they can use look at respiratory secretions, and here results are usually available in 2 hours or less. So this is a quicker study. And then finally, we can do blood analysis. So the quantiferin gold and the T-spot TB tests are a couple examples. These show how the immune system responds to TB, not if the infection is latent or active. Note that TB can be active usually 10% of the time, or latent, which is more common 90% of the time, where the patient is not infectious. Be on the lookout for new TB tests. There's one called the Gene Expert Omni that's coming down the pipes for future point of care testing. So how do we treat tuberculosis? Usually we use different combinations of these 4 medications to kind of tailor to the patient's individual infection. So one way that you can remember these TB meds is by remembering RIPE. So RIPE is just the first letter of each of these medications. So the first one is rifampin, and be aware that this causes red or orange body fluids, so you want to make sure that you're giving your patient a little bit of warning, I guess, so that, if their tears are orangish, or their sweat, or their urine, they know that that's an expected side effect. Isoniazid can cause peripheral neuropathy, which we can help to correct by giving pyridoxine or vitamin B6. The next one is pyrazinamide, and that can cause hyperinuria, which can lead to gout, right? Urea can lead to gout, so that's one of the side effects of that medication. And then ethambutol, you want to watch for this one because it can cause optic neuritis. Know that all of these meds, though, can cause hepatotoxicity, so we want to make sure to be monitoring for that. Also, some patients need to use second-line drugs as well if they have an atypical form of the tuberculosis bacteria, or if they have developed a drug-resistant variation. In nursing practice, we really, really, really cannot stress enough the importance of medication regime adherence or regimen adherence. The combination drug therapy is really effective at treating TB and preventing transmission, but it goes for a long time. So typically the initial phase of treatment is 8 weeks, and then there's a continuation phase that can last another 18 months. So, it's not remembering for 10 days to take an antibiotic. This is a commitment. So, what we want to do then, and is just stress how important it is to take your meds as prescribed. But sometimes what they'll do as well is do direct observation therapy, where a public health nurse goes to the patient's house and they can check in, make sure that the patient's taking their meds, help set meds up, do all that. The other thing that we want to consider is respiratory isolation. So the patient, for the first couple of weeks they're on their meds, they're still going to be contagious, so we want to make sure that they know about that, that they're wearing a mask while they're out and about, if they have to go out, but just the importance of hand hygiene, the importance of, the housemates, think about that too. Our activity this week in class, we're going to talk a little bit more about that, but just things to keep in mind. A couple more education pieces. Again, we really want to teach how to minimize the spread of TB and the medication adherence. And then the last thing is to really encourage a healthy diet. So patients, as we said, one of the signs and symptoms of TB is weight loss. And so we really want to encourage patients to eat a healthy diet so that they can stay strong and fight the tuberculosis off. What information is most important for a nurse to include when teaching a client with tuberculosis about the prescribed first-line drug therapy? All right, so go ahead and read through these and put me on pause and hit play when you're ready. All right, so the answer to this one is B. So all of the drugs for tuberculosis are liver toxic and can cause liver damage. Drinking alcohol compounds the damage and should be ingested only in small quantities, if at all. Rifampin, we know, can lead to orange fluids. And while the patient should be taught about that side effect, they don't have to report it. We expect that. We want to increase fluids for patients, not decrease fluids in our patients that are taking pyrazinamide. Because, remember, we want to prevent the gout or the hyperuricemia. And then ethambutol, so the visual changes that are associated with that are serious and not temporary. So it's not that it's a temporary vision change, it's permanent and it's serious. It can cause optic neuritis and can lead to blindness if they don't stop the drug when symptoms start to present. Chapter 32, Care of Critically Ill Patients with Respiratory Problems. Alright, so when a client breaks a rib, it's considered a fractured rib. Flail chest happens when two or more adjacent ribs are fractured. And if you think about what the ribs do for our body, it kind of helps to provide stability. And so when we have a break, and especially when there's more than one that are broken next to each other, then it can lead to rib cage instability and possibly organ injury. If there's a puncture in the lungs or the pleural space, it can cause a pneumothorax or a hemothorax. On the left side is where our spleen sits, so left broken ribs can lead to splenic injury. Broken ribs on the right-hand side can cause damage to the liver. The liver is on the right side. So what do we do about it? We can't really splint the chest. We can't, or the ribs. We can't put a cast on them. So we want to do a couple interventions. Oh, and I should note too, there's something called a paradoxical chest wall movement, and that is what we see with flail chest. It's where we have this inward movement of the thorax during inspiration and an outward movement during expiration, just because the stability of the ribs has been compromised. So for education, we don't want our patients to stop moving around. Think about what happens when you are just taking shallow breaths. The patients can develop pneumonia in the lower lobes, and they can also develop atelectasis. And so those are things that we want to avoid. It hurts though. It can be painful, coughing and deep breathing. If you think about when the lungs expand, it puts pressure on those ribs that are broken or fractured, and that it causes pain. So one thing that we can teach our patients to do is to splint the fractured area when they're doing their coughing and when they're doing their deep breathing for support. And to splint, they can either use their hand or they can take a pillow or something and hold that against the outside of their body, just to kind of help to keep everything in place. The other thing is that in flail chest, so flail chest obviously has more potential serious consequences. So we always want to follow our ABCs, our airway. We want to make sure that they're breathing. And so there is the potential that if the damage is severe enough, that the patient is going to need to be mechanically ventilated. All right, a pneumothorax is where a patient develops a collection of air in the pleural cavity, and remember the pleural space is kind of that place where your lungs sit. So air forms in that cavity, either as a result of trauma, TB, chronic respiratory disease, but the collection of air as it develops between the lung causes the lungs to collapse. So risk factors are things like smoking, trauma, we just talked about rib fractures, but also stab, puncture wounds, and then any pulmonary disease that affects the lungs' ability to expand. So normally when we breathe in, the lungs expand. We exhale, they deflate. Not totally deflate, but the air goes out. So there's 4 types of pneumothorax. Spontaneous, which just can happen, right? Just like what the word sounds like. Traumatic, so from blunt physical trauma, which can or cannot be penetrating. Iatrogenic, which basically just means it happens as a result of something that a provider does or from a procedure. So things like a thoracentesis, maybe they're getting a biopsy done, or the vent pressure is too high, central line being placed. And then the last one is a tension pneumothorax, and that can happen in the presence of trauma, infection, CPR, or in ventilation. So then we'll talk about chest tubes a little bit more on the next slide. As you can imagine, it's pretty painful. The patient's going to have a hard time breathing. They are going to have increased rate of respiration. They're trying to get oxygen. Heart rate's going to be up. Blood pressure are going to be low. When you're auscultating lung sounds, you're not going to be able to hear anything over the area where it's collapsed. For diagnostic tests, we do x-ray, as you can see here. You can get a pretty clear picture of where the lung is not expanding. We can do ABGs. We will probably expect to see low oxygen, possibly respiratory alkalosis, because the patient's hyperventilating, right? So they've got a loss of CO2. ECG, we can watch and see how the heart is doing. And then treatment is to insert a chest tube. And chest tubes remove air from pleural space and help to restore that negative pressure environment. They put the chest tube into the pleural space, connect a suction, and pulls out all the air. If there's also pus or fluid, then they can do that as well. It also allows the lungs to expand fully again. All right, and then here's just normal EBG values again. It's nice to see them. So just make sure that you know these, know the difference between PaO2, which is the partial pressure of oxygen in arterial blood, between 80 and 100, and then your SpO2, or your oxygen saturation. On this slide it says 97 to 100, but again, keep in mind that can look a little bit different. The closer to 100, the better, but usually mid-90s and up is sufficient.